Excellent.
Irritable bowel.
Irritable bowel, and we'll go ahead and go through our learning objectives. I printed it out so I didn't have to talk backwards. Understand this is not always initiated by stress. I think there's some stigmatization going along with the disease. Realize that irritable bowel syndrome is a compilation of different etiologies, and that really affects your treatment plans. Understand who needs a workup and who does not, and then explore different treatment options. So,
Yeah.
let's go.
It's a syndrome, and so it's even by its own definition, there's like 4 subtypes, right? So it's a whole. It's almost just like this.
But I think even in each subtype, there's different etiologies for what's going on, and so that's why these people need close follow-up. It impacts their quality of life so much. You want to keep trying things so you can find something that improves their quality of life.
Yeah, and on quality of life, it was shocking to me. So 7% of adults, usually under age 50, but by the time you make this diagnosis, will get irritable bowel syndrome diagnosis.
Yeah, that's a lot.
It's a lot, and when they ask these people, they were willing to trade 10 to 15 years of life for an instant cure. Wow.
Yeah.
That's really...
It's amazing.
It's amazing. So...
Is it that serious?
Well, I think if you have the symptoms...
it impacts your social... You get social anxiety. I mean, again, why we can't say anxiety causes it is because actually the disease causes anxiety. And people are afraid to go out.
Yeah.
They're afraid to go out to eat, all those kinds of different things. So
I think also one of the things that was interesting when we talk about treatment is reassurance.
yeah, that there isn't any serious that we've ruled out serious things.
Yeah.
I mean, it's serious disease. But
it is, but if
it's not cancer.
It's not going to kill you.
Right.
You're not going to have to take. Well, there's some of the meds that have significant side effects, but it's not going to be horrible. Like I'm taking prednisone or. I have to do a TNF alpha inhibitor. It's not like Crohn's or ulcerative colitis, but reassurance works extremely well. And
right.
So my ICD-11 suggestion is some of this.
Yeah.
Hand holding.
Yeah. No side effects whatsoever.
Exactly. Or maybe pass some C. diff or VRE or something, but
yeah.
And I did look. They do not have a code for hand holding.
Oh.
There is one for reassurance.
Charge. Yeah. Oh, there you go. There you go. This is the handout and the information is from the New England Journal article, which was a very good article. And they made a good point that it's probably a 50-50 split that people that do have stress, in fact, there are a lot of times you can ask about domestic abuse and those kinds of things. That population has a high incidence of irritable bowel syndrome. So 50% the stress can induce the disease, but just the opposite. The other 50% the disease induces the anxiety. So again, kind of try to remember that. I think the definition of irritable bowel is that they have chronic symptoms that have to occur once a week for 3 months solid over at least a 6-month period.
Very good. That's the Rome criteria.
You like that?
I'm impressed.
Who needs Rome criteria, for God's sake? That's a sentence.
Exactly.
I'll never get published with a sentence instead of a criteria.
No.
Though. There you go.
So I think we talk about reassurance as a treatment. So I think before we can reassure the patient, we have to reassure ourselves. And so how do you make the diagnosis? And the article changed my thinking about this, and it was definitely different from what I had learned in school.
Same here.
Yeah. So what do you guys think?
Just a diagnosis.
Very good. Because I was taught it's one of exclusion.
Right. Work everything up and rule it all out.
And then send them to the psychiatrist.
Yeah,
for their
exactly.
sertraline.
Exactly, or start them on something.
Yeah, and so the suggestion in the article, which made me feel better, because I've always felt like, gee whiz, I really don't feel like I want to send this 24-year-old person for a colonoscopy and all this invasive testing, is to apply the Rome criteria, if it fits well, to do limited testing. And what they suggested was a CBC, which seems reasonable to me, maybe an inflammatory marker.
Like a CRP or ESR.
Yep, and then basically a fecal leukocyte or a testing for inflammation in the stool. And if you do that, that's probably enough. And
Now, I will add, if it's a diarrhea predominant, I'll test for celiac disease, because
Yep.
that is one where I feel that needs to be excluded.
I agree, and there was a high component of sort of overlap.
Yes.
So I agree, I'm sorry I left that out, but
Yeah.
I do a tissue transglutaminase. They have a celiac panel here, and they just look for celiac, it'll come up in the labs.
Yeah.
And it's
I don't
available.
think they need biopsies,
Yeah,
you know,
no.
we don't need to go that extensive, but if their blood work's panel's negative,
Mhm.
I kind of like to test for that quite a bit, so. So who needs the, more testing than that? Even though they fit the Rome criteria, what patients would you send for either imaging or a colonoscopy?
Red flags, like
Yeah.
blood,
Red
Blood,
flags,
blood in the
weight
stool,
loss.
waking up
Weight
at
weight
night.
loss, all your red flags, right? And just age over 50, because they meet the criteria to get it anyway. The subgroup that I see people miss is somebody with a family history of inflammatory bowel disease or colon cancer.
Mhm.
And I don't mean colon cancer at the age of 85, but you know, those people that are higher risk anyway. So, and I'm not sure how many times we ask about family history of inflammatory bowel disease. Sometimes it's a little frustrating because patients don't necessarily even know that uncle had Crohn's or something, you know. You could ask them if they've ever had intestinal surgery or anything like that, they might know that fact a little more. So those people need more workup.
Yeah, agreed. Yeah, I actually think a good family history is, but yeah.
Yeah,
And then I didn't know how much time, there's some biomarkers that are potentially coming. Interesting, and the thing in Europe was sort of interesting. They
Yeah.
sort of have almost, it's like a quarter of the people that have diarrhea predominant probably have a bile acid malabsorption
Yeah.
problem. And they have like a precursor blood test. It's like the methylmalonic acid. You
right.
can draw it, and if it's high, then it's suggestive of bile acid malabsorption, and we don't have it here. And then they've looked at little antibody testing, but nothing that you can really do clinically. So it's kind of apply the Rome criteria, make sure there's not inflammation or red flags, and that's pretty much all you need to do. And the colonoscopy was interesting in that it didn't provide much long-term reassurance for the patients.
Yeah, sometimes you want to do it for that because
Yeah.
they are worried about something, and I think I've fallen into that.
Me too,
Before.
definitely.
But it's kind of like somatization. Again, I don't want to imply that irritable bowel is somatization, but it's like more testing does not lead to reassurance.
Yeah, it made me feel good about what we do in the clinic, because the colonoscopy is invasive, costly, and
It can have
We-
bad effects.
yeah,
for
we can
no
actually do
benefit.
better just with that good, reassurance about this is
Yeah.
really what's going on.
Right.
I don't know if I wanted to spend too much time on pathophysiology. I found it fascinating. There's any number of
You
things.
would.
I know. Everything from there's probably some infectious causes. Autoimmunity probably plays a role, and that's probably why it fades by the time you get older. There's some families that have chloride and sodium channel
Yeah.
stuff, but there's lots of great rat
We'll
studies. We'll
stop
spare
you right there.
Should we go on to treatment?
I think you make a good point in your handout about the probiotics and different things, which is a very benign thing to try, and to go ahead and do that. So,
How long
Yeah.
should you do probiotics? Indefinitely or for?
that's a really good question
Great
because it's
question.
not studied very well. I would say, it could be like any other treatment. You could try it for a year and then try to take them off and see if their symptoms recur. If they're responding to it, again, I just don't see anything bad about it. I have horses, and actually probiotics in horses helps prevent one of their more intestinal issues. And so sometimes, why not extrapolate to people?
Exactly.
It's better than extrapolating from rats.
Exactly. Horses are just so much more lovable. They're hard to
They are. They don't have
sacrifice.
those, like,
Yeah, no.
Bald tails. It's gross. Oh my God.
I do have some about probiotics. I have had some people that they've responded to it, and these symptoms are so horrible for them, they won't want to go off of the probiotics. They're just like, man, this is like gold, and it changes their life. So I've had a few home
And we
runs.
have them here. You can prescribe them from the VA.
Yeah,
can't you?
we do. The caveat that I would say about we have probiotics here, but it's actually, the probiotics is a super interesting area in medicine that will come, more is coming, but there's millions and millions of different strains of things, and we don't know which ones are important. The thing that I actually ask them to try the probiotics outside the VA over the counter if they can afford it, because we provide lactobacillus.
Oh, okay.
So ours is only lactobacillus. It's
Yeah.
not.
You know what, I'm gonna suggest something I just learned this week, is that, the Creighton School of Pharmacy has an online access for any health professional, and they actually have a fellowship in natural medicine.
Oh, really?
So they have this, they would have the most science to be able to apply that, so that might be worth us
Yeah.
asking them what they would suggest we would use. And probably in Germany and other places, they're probably a little bit better at studying some of this stuff, so,
Yeah.
little food for thought.
Absolutely. Other treatment. And I think in treatment you can't. I think you have to break it down into the diarrhea folks and then the folks that have constipation. It's just
Right.
two different things.
Right.
And
You're going for symptomatic.
So you might have to change it up a little bit.
Exactly. That's true. I mean, the disease can evolve to different, you can be diarrhea predominant for years and then become constipation predominant, so that's a good point.
So I like the FODMAP diet.
You like that word.
I do.
What I like about it is actually there's an app for it, so you
Oh,
can,
I didn't know that.
yeah, you can educate patients to use that. The other part I like about dietary is that these people, I think, need a lot of close follow-up. They got daily symptoms pretty much, and having a dietitian that they can talk to and who can continue to they could keep a food diary, see if there's any idiosyncrasies in their diet or anything that would help, so.
Yeah,
What is a FODMAP diet, Dr.
it's-
Birch?
It's basically stone fruits, artificial sweeteners, and the theory is that these sugars are metabolized by your gut flora.
Yeah.
And in certain people, their gut flora metabolizes these sugars differently, and they make kind of toxic byproducts, and then those byproducts are irritating to the colonic mucosa, and so it causes the symptoms.
Artificial sweeteners?
Yes.
Yeah.
The high fructose corn syrup, I think, is the devil, but that's
I
another
do
talk
too.
for another
But anyway, wait a minute.
day. We would not
We
digress.
digress. We never digress.
But high fructose corn syrup is on that list, and go try to look about trying to. It's actually hard to buy something that's sweet without it in there.
That's blasphemy in Nebraska, right? All the
it-
farmers.
It is, yes. Oh, don't encourage me.
Don't get him going.
Yeah.
We'll never get done.
Exactly.
You know, you mentioned the thing about the testing for the bile secretion, and especially in people that have cholecystectomies, but almost anybody with diarrhea predominant, I actually will try a bile binder as a treatment.
Yep, cholesterol.
Yeah. It actually, I think I've had a lot of success with it.
Yeah, and if they wanted to do something, I like the peppermint oil. I didn't realize that there's a sustained action preparation of that. That seems to help. It causes smooth muscle relaxation. And I'm a big fan of just basically simple antispasmodics.
Yeah, I agree. Because I think that's what causes more of their distress sometimes.
The
so.
reassurance is huge. And then also what's interesting, one of my favorite ones in this was a gluten-free diet. You shouldn't do it the FODMAP diet because when they did both together it's so restrictive and didn't help. But if they didn't respond to the FODMAP, there's a certain number of them. And it was
Even though they don't have celiac disease,
Yeah,
it
so
should be mentioned.
they tested negative for celiac disease, and they put these people on a gluten-free diet gluten-free diet, and then they gave them a placebo or something containing gluten. And there was a huge difference in the people that were getting gluten and didn't know it. And some of the thought is that the gluten containing foods are sort of close to the FODMAP foods, and so maybe that's why there's benefit. But the gluten-free right now, it's so easy. There's like whole sections you can, well, it's not super easy, but it's a lot better than it
It's a lot
was.
easier to get food that's gluten-free
And
now.
I find a lot of people want to try a gluten-free
I
diet.
know, it's
So-
crazy. I love bread.
I do too, but if they want to try it, that's another thing they could
Right.
do. But do one or the other, don't do both.
Right.
Um,
Exercise is important. That has
Yep.
its own effect on gut motility. I really like nortriptyline in diarrhea predominant. It's got your anticholinergic effects, and it seems to help with spasms and things. Again, probably due to effect on gut motility. So
and the other one that I learned from this was on Dancitron.
yeah, and I haven't used that before much.
I haven't either because they have a very expensive brand name
Right.
medication, but it's essentially just a little different formulation of Zofran or Dancitron, and there were some studies with.
Oral, it's easy to take.
It's now readily, we can get it fairly easily. It's generic, so if they're having a lot of symptoms, not nausea, but it helps
Right.
with the GI motility issues in these diarrhea predominant people. So
Right.
worth a try. I
Yeah.
haven't used it, but
I'm going to.
Yep.
I'm reading
And
that.
constipation predominant. Should we
Mhm.
talk about that?
Yeah, yeah,
I think they suggested Miralax.
yeah.
Which I think
I
is
like that
reasonable.
one.
Sometimes a little bit hard to titrate. I like to just send on Ducasate and then
Yeah,
some of the fancier ones, essentially the ones that are listed. It's on. This is 2 pages.
Yeah.
I'm sorry. I thought it
there's
was on
a
the
nice
back.
chart from the New England Journal on the back.
But it was on the back.
Treatments.
This one didn't cover, but those are almost restricted. And I kind of
Yeah.
ask GI. I feel like if we're getting to that point of using these really expensive medicines, at least one time go see the specialist. Make sure that we've tried everything else first, because they're very expensive. Rifaximin you can try, but again,
Right,
very, very expensive, and I haven't had a lot of trouble. I can't actually remember sending somebody for one of these fancier
no,
drugs.
I haven't.
So,
And then fecal transplant. Always at the GI doctors, who
yeah,
are the only ones who love this concept,
exactly.
are always trying to promote that, and that they're actually doing studies.
Yeah,
I'll
otherwise,
go with probiotics before I go with
Me
fecal
too.
transplants, though. So,
not well studied, so you don't
and
know.
probably not well accepted.
Yeah,
It's
exactly.
not right.
It would probably have to
So
be a
they're trying
really
to
serious case.
convert that FMT into a pill,
Yeah,
so that like it's well like.
Oh, they-
that would be more, a
They've
little more
already done it.
acceptable. Don't
They
you
are pill
think?
you can take.
Oh, they have already made that.
Yeah,
Oh, okay.
little capsule.
Or they put them to sleep and then.
Yeah, because last
Uh,
year when I was doing research, many patients they didn't want to do it because
Right.
it's that yuck factor. But
Right.
still, like in C. diff patients, 90%
Right.
patients get better with it.
Yeah. There you go. See?
Well, I thought we'd sum up, but they've left.
Oh, I think, yeah, we're
We got distracted.
Yeah, the learning.
Oh, and I forgot my
They want to go see patients.